This conference will now be recorded.
There we go. And we will post a copy of the recording and the slides to our website within about 24 hours, hopefully this afternoon, but sometimes it takes a little bit longer. And you'll be able to download it at shpllc.com/webinars. That's shpllc.com/webinars. Okay, so by way of introductions, today we are joined by Michelle Madison and George Reinhardt of Morris, Manning, and Martin. They'll be covering the recently passed surprise billing legislation from here in Georgia. And then after they're done, Mike Scribner will be sharing a brief update about the COVID relief funds. So with that introduction, Michelle, you are free to take it away.
All right, thank you. Hello, everyone. We are going to cover the Georgia surprise billing law first, and I will cover that part, and then I will turn it over to George, who is going to cover the federal law so that you are familiar with both provisions. So first and foremost, our lovely disclaimer. And so we're going to start with the state of Georgia, which this law went into effect January 1st. And the concept was when patients go to a facility that is in network with a payer, like an Aetna or United or Blue Cross Blue Shield, but the anesthesiologist or the physician that's on in the emergency department is not in network, they were trying to prevent the patients from being what they call surprise billed for the balance of the services of what's not covered when that individual physician or provider mid-level is not a participating provider in the insurance plan. So really it's a consumer protection mechanism, and it's both at the state law level and at the federal level. There is an exemption under this law, and that's for ERISA plans. So if you are an ERISA plan, then you're covered by federal laws, and under the federal laws, there are certain minimum requirements that you have to satisfy as an insurance plan, whether it's a retirement plan or a health plan. And the ERISA exemption moves those plans out from being subject to the surprise billing law. So we're going to talk in a little bit of detail about that. The other thing I wanted to mention is under the statutory references, and if anybody would like to have that statutory reference, it's OCGA, so Official Code of Georgia. It's 33-20 and then capital E-1, and then it goes through E7. But from this standpoint, this does not apply to vision plans, and it doesn't apply to dental plans either. So they distinguish between two types of services. One is emergency medical services, which is what we normally see, especially when we're dealing with the EMTALA definition. This matches up. So any kind of medical care or medical symptoms that would place the patient's health in serious jeopardy, serious impairment to a bodily function, or dysfunction of any bodily organ or part. So it's the same definition of emergency services that applies when we do an emergency medical screening in the emergency department to determine whether or not a patient has an emergency medical condition. These are the categories of what's considered emergency medical services. And this for any of our facilities where we practice, if there are any facilities on the line, this is where your services are rendered in the emergency department. So and we've broken this down into two parts. You've got emergency services, and then we have non-emergency medical services. And the law in Georgia applies to both, with a little bit of a nuance, but not much of a difference between the two. So first and foremost, let's say that for those of you that are physician practices on the line, that your doctors do not participate in Aetna, but your hospital, where your physicians are on staff, does participate in Aetna. So it's an in-network facility, and you've got out-of-network providers who might be on call, and a patient presents to the emergency department, and so it's for emergency medical services. So regardless of whether the facility is in-network or out-of-network, obviously the rule has always been you can't require, if I'm an insurance company, I can't require the hospital to get a pre-authorization prior to that patient presenting for emergency services. So that's always been the rule. And the patient is still going to be responsible when they present to the hospital for their out-of-pocket, cost share, deductible, whatever their co-insurance amount is. But now, instead of, if I'm an out-of-network doctor with Aetna and this patient has Aetna and I bill the patient, and let's say Aetna's out-of-network benefits are $100, but my bill was $600, in the past, we may have just balance billed that patient because we weren't participating, so we didn't have a contract. And In those instances, we would have just balance billed them the difference. Now we can't do that. The insurance company instead will pay you a certain amount, and this is how the amount is calculated. It is the greater of the verifiable contracted amount paid by all eligible insurers for the provision of the same or similar services. And I want to be very clear about this. When the government set up this rule, they decided that the way they're going to define contracted amount is the amount, it means the median, okay, of an in-network amount that would have been paid during the 2017 calendar year by an insurer for the emergency services provided by in-network providers in 2017. And then the government's going to increase that each year with a CPI inflator. So some of the insurance companies have said, well, in 2017, we may have paid more for some of these services than we pay today. And what the state has announced is that they have partnered with what's called Fair Health, and Fair Health has a database of insurance rates to determine what this median amount is, to determine what the contracted amount would be that you would receive as payment. Now, there's a little bit of confusion with regard to the Fair Health database today, and I have contacted the Office of the Insurance Commissioner to get more information. But that database is a subscription database, and so we're just trying to confirm whether or not providers and insurers can have access to a database because the state has contracted with them to provide this contracted amount, or whether or not we're going to have to get some kind of download or extract. So that's still a question mark that's out there, and I'm waiting to hear back from the department at this time about that question. But that's one of the amounts, and remember, this is the greater of. The second part is the most recent verifiable amount that the insurer had agreed with the non-participating provider for the same services when that provider was in network. So in my example, if we are out of network with Aetna today, but let's say 6 years ago, we had a contract with Aetna, then they would look at that contract with Aetna and see whether or not it covered the same emergency services. And if it did, and that's higher than this median amount from 2017, that would be the amount that would get paid. Or the insurance company has the discretion to pay even more. So I know some of you are thinking, well, that's probably not likely in light of these other two realms, but these are the three categories of payment. So as I'm the non-participating provider, I don't take Aetna, I'm seeing the patient in the emergency department because I'm on call, I'm going to bill the patient for their co-insurance deductible or copay in the same manner that I would as if I was a participating provider. And then the insurance company will pay me the greater of one of these three categories. So that's the emergency services side. We have to, from an insurance standpoint, the non-emergency medical services will be covered as well, but in a separate way. And then a surprise bill, just so that you all can keep it in check with how they define surprise bill under the rule. That is when you have an in-network facility, but an out-of-network provider. So if you're both out-of-network, it falls into a different bucket. A surprise bill is out-of-network provider, in-network facility. So on the out-of-network providers for the surprise bills for non-emergency medical services, it's the same kind of calculation. Same thing, the greater of. So let's say that I am at the hospital and I'm going to have a procedure done, non-emergent, but a medical service that my doctor has ordered that are medically necessary, because remember, insurance companies typically don't pay for non-medically necessary services, but I'm still out of network and the facility's in network. So the hospital would bill the insurer for the technical fee. They're in network, they'll get paid, they're in network. Patient will receive a claim for their copay, deductible, and co-insurance under in-network benefits. I'm an out-of-network provider, I'm going to bill them in the same manner, but the insurance company is going to pay me the greater of one of these subgroups. So the verifiable amount based upon the Fair Health database from the 2017 median, or the amount that I had under contract with the insurer. And I think something that's really critical here is look at the first category. It's the verifiable amount paid by all eligible insurers for the provision of the same or similar services. But the second bucket is for the same services. So if you had a contract, in my example with Aetna, and you were in network, but you were only in network for, let's say, physician office services, which didn't include procedures in the hospital, then that category of reimbursement under your old Aetna contract is not going to apply here because it's not the same service. Or the insurance company can obviously pay you more if they feel like, based on the complexity and what the patient needed, that they could pay you more than these other two amounts. The patient does still remain responsible for their out-of-network obligations under their health plan documents. Now, there is an opportunity that you could still bill a patient for a service, okay, even though you're an out-of-network provider, and it's a non-emergency service, and that is that concept of an informed consent by the patient. So if I'm an out-of-network provider and the patient is seeing me for non-emergent services, I can tell the patient, I'm out of network with your insurance company. Do you want me to still provide the service to you? Based upon our charges, that service would be X, the estimate of those charges. And if the patient consents, then you can bill that patient. I look at it kind of like the ABN process with Medicare. When you have a Medicare patient and it's a non-covered service, you give them the advanced beneficiary notice that says, this is what the service is, this is our estimate of the fees, this is the estimate of what your out-of-pocket is. Do you still elect to have this non-emergent service? And if the patient says yes and signs that consent, you then have authorization to bill that patient directly for those services. So it's important that if you're going to engage in that kind of activity, then you have to get the written consent of the patient. Now, there's another provision in the law before I jump to this arbitration provisions, and that is if I'm a provider and the patient wants to be referred to another provider, I could also notify the patient that that other provider is not in network, could have higher rates, and get the consent of the patient to provide the care as well and be able to bill for the service. So there are ways that you can get the informed consent for non-emergent services. Emergent services are going to fall under that first bucket of the greater of those three categories. Now, if a provider gets paid by an insurer, so let's say that the insurer says that the highest amount based on those three categories for services was in the emergency department $100. But we know in 2017, we were getting paid $250 by most insurers for our visits in the emergency department. We as providers could file an arbitration request with the Office of Insurance. And that arbitration request has to be made within 30 days of the receipt of that $100 payment. And when we send in that arbitration request to the insurance company, to the Department of Insurance, we also have to send a notice to the insurance company so they're on notice. And then the arbitrator, the way this works is the insurer will propose an amount to pay for the service. The provider will propose an amount to pay for the service, and the arbitrator picks one or the other. They don't take the two amounts and add them up and divide by two to get an average. They pay one of those two numbers. And whoever loses is then responsible for the fees associated with the arbitration. So if you go through the route of going to arbitration through the department, you will be proposing a number, and then they will pick one. And if they pick the insurance company's number, you may be out of pocket for those arbitration expenses. The other thing about the arbitration is in the law, they have said that these arbitrations are going to be documented and tracked by the Office of Insurance. And then they're going to give a report to the Georgia Assembly about the number of arbitrations they had, how many of them they went with the insurer, how many of them they went with the provider, and what the average amounts were so that they can evaluate whether or not this process is working in the state of Georgia. The other thing to be aware of is that there are proposed bills and there's talk out there about listing out on a website how many in-network facilities have out-of-network providers and scoring facilities based upon whether or not their providers who are hospital-based are in-network or out-of-network. So we will see that as well. So patients will be informed when selecting a hospital to go to, whether or not most of the providers are in-network with their insurer or out-of-network. So you're going to see more education, more information about this moving forward. So now I'm going to turn it over to George to talk about the federal law. And George, you can just let me know when you want to move from slide to slide.
Yeah, that sounds great. Thank you, Michelle. Would you go to the next slide, please? Great. And so, Michelle just covered what Georgia is doing. The federal act actually lags behind just a little bit. This was passed just in December of 2020. So I do want to sort of emphasize at the beginning of this, we're looking for regulations to come out and hopefully give kind of more framework to this. Later in 2021, they're scheduled to come out in July. So please do sort of stay tuned for those, but hopefully that will provide some additional guidance. But today I'm really going to try to hit some of the highlights of the statute. Now, as Michelle mentioned a moment ago, the Georgia statute is mostly applying with respect to health plans that are subject to the state law. The federal act, should pick up those ERISA plans and ones that are subject exclusively to federal law. And as we go through, you will see many of the same sort of themes that Michelle just discussed with respect to the Georgia law, although there may be a few differences as well. Michelle, would you go to the next slide? So as with the Georgia law, the Federal No Surprises Act has certain restrictions around billing patients for emergency treatment. What this requires is that when you treat someone for an emergency medical condition, which, as Michelle mentioned, is really what we think of in terms of how it's defined in EMTALA. When someone is treated for that, a facility or a provider cannot require a prior authorization, and they must treat the patient as though she was treated in an in-network setting. What that means is that the patient's payment obligations for these emergency treatments are limited to what they would otherwise pay if these services were provided in an in-network facility. Now, under the Federal Act, that is referred to as what is called the recognized amount. You use the recognized amount in order to determine, again, those cost sharing obligations. That is really the recognized amount here under the federal statute. There are a couple of ways to determine it. In most cases, it will be similar to the median amount Michelle discussed a moment ago. And that is really the median amount that the healthcare plans pay for similar services. So the patient is obligated only for that cost sharing amount. Beyond that, the facility must collect from the payer the out of network amount, which is really what the parties either agree upon or what they subsequently decide through arbitration. Michelle, would you go to the next slide, please? Now, again, similar to the Georgia Act, the Federal Act also applies with respect to non-emergency treatment. Now, the non-emergency treatment rules come into play when you have basically an out-of-network provider that is providing services at an in-network facility. Now, similar to sort of the patient's payment obligations for emergency services, the patient is only obligated under the federal law to pay his or her cost sharing amount. The remainder of the amount and of that out-of-network rate is again determined really basically by what the plan is willing to pay, and if the parties do not agree, what they subsequently settle through arbitration. Michelle, could you go to the next slide? Thank you. Now, unlike with emergency services, the patient, as with the Georgia statute, can voluntarily consent to receive care from an out-of-network provider at an in-network facility and assume the balance of those financial obligations. In order, though, for the patient to assume those, they must be provided a written notice and provide their own written consent. Now, the written notice, there are several requirements under the statute that we expect to be sort of refined through the regulations, but it must provide the patient with an estimated amount of the cost, and it also must provide the patient with a list of in-network providers who are available at the facility. Now, for the patient to consent to this, they must execute the consent, provide it to the provider and the facility within 72 hours of actually receiving the service, or if the service is scheduled within 72 hours, then at the time the services are scheduled, the patient must execute the consent. Now, the federal law specifically prohibits patients consenting for certain ancillary services, things like anesthesiology, radiology, that are typically provided at our facilities, by a designated group where the patient has very little say. Michelle, could you go to the next slide? Thank you. So, in the event that the insurer and the facility or the provider do not agree on the amount that is actually owed with respect to services that are provided, the federal law provides, similar to the Georgia law, a sort of a dispute resolution process. The way this works and the way it is initiated is if within 30 days after there has been an initial payment by the plan, the facility or the provider disagrees with the amount, they initiate a sort of an open negotiation process. Now, if that fails to render any results within 30 days, then they may move to arbitration, that is basically initiated by filing with the secretary within 4 days of the end of sort of that open negotiation process. Similar to the Georgia law, this is baseball style arbitration, which again means that the arbitrator may only select one position, either the position of the facility or the provider, or the amount that is submitted by the payer. Again, as with Georgia law, the losing party is obligated to pay the cost of the arbitration, and if the parties eventually settle, then the parties split the arbitration cost equally. Michelle, could you go to the next one? So again, as I mentioned a moment ago, each side submits its own basically offer of what it would accept as payment. This must be done within 10 days of the selection of the arbitration, the selection of the arbitrator. Now, this again is an area we expect to really be refined through the regulations, but the statute does say that in coming to a determination, the arbitrator cannot consider what we term the usual and customary charges, and it can also not consider or take into consideration the Medicare or Medicaid rates. It can, though, in choosing between the amounts to pay, it can consider things like the training and experience of the facility or the provider, the complexity of the case, and basically what the plan or the insurer pays for similar services. Now, one thing to very much keep in mind with respect to this baseball arbitration, if it ever gets to this point, is that it's crucial that a party submit really its supporting documentation and things that support its position. This is not a situation where the arbitrator can sort of split the middle or split the difference. It has to choose either side. So it's crucial that in going through the arbitrations, and this applies with respect to the Georgia Act as well, that the parties must put forward documentation and evidence that really supports their position. Michelle, could you go to the next slide, please? And lastly, the Federal Act is going to require each provider and each facility to give notice of sort of these surprise billing regulations. Now, this is going to require a one-page notice that will be posted on websites of each of the provider and the facility. The notice must describe both the federal prohibitions against balance billing, as well as the state prohibitions, and in addition must provide the contact information for the facilities, or pardon me, for the agencies that may be contacted if the facilities or providers fail to comply with this. So again, I want to go ahead and wrap up here and then we can take some questions. But I do want to emphasize with respect to the Federal Act, we do feel as though some more framework will be coming out about this, probably some additional clarification, hopefully later this year so you can be prepared to begin in 2022. And with that, Michelle, I can turn it back over to you for questions.
Okay, so Aaron, if we have any questions or if Mike Scribner wants to start, that would be fine too.
Yeah, I got a couple. First off, does this apply to ASCs as well, or is this just for hospitals? And that's a question on the state and the federal side.
So on the state side, bear with me 2 seconds.
Geez, Michelle, I didn't think that one was going to throw you for a loop.
Okay, thank you, Mr. Scribner. Mr. Scribner, the answer is hospital, ambulatory surgical treatment center, birthing center, diagnostic and treatment center, hospice, or similar institution. I just wanted to make sure I gave you the full answer.
But I heard hospital, ambulatory surgical. Is that hospital?
No, hospital, comma, and ambulatory surgical treatment center, birthing center, a DTRC.
And I heard imaging center in there as well, I guess for the reads.
Yeah, that's right. So diagnostic and treatment centers, and then hospice or any similar institution.
Okay. All right. Kind of my second question is a little bit bizarre and out of left field. As the reference-based plans have become more common, where there is no network at all, it seems like this only encourages that kind of bad actor activity. Am I off in that? It seems to give them a pile of cover. Michelle, is that right?
Do you
know
mean
what
because, no, give me a little more detail, like where somebody's not going to contract and allow the participating
like
providers
like an ELAP, it's a HealthGram, it's those that'll say to Colquitt, I don't have a network. When you go to Colquitt, I'm gonna pay Colquitt 150% of Medicare, and I'm gonna help you be held harmless from any surprise billing. That's what they say. It seems like all of this law just gives them a lot of coverage, a lot of protection just to keep doing that to us. And like we've just built in a bunch of protection for a bunch of people who are trying to harm us.
Mm-hmm. So I think there's two different ways to look at it. Does it help them? Their methods, and my recollection is that they'll go and say, well, this is our usual and customary, and under the health plan, we only pay usual and customary, so therefore we're going to pay this rate. I think we have to wait and see what that Fair Health database looks like, because that now might determine what those rates should be versus what they were using for usual and customary. Because I think our biggest argument with those kinds of actors was that their usual and customary rates were not usual and customary, but they were way lower. So this new ability to have a database that the state has recognized as a way of setting a median is helpful. But I don't think it stops those actors from acting.
Okay. All right. Yeah, I hear you. It feels like it kind of cuts both ways. It might set a higher price that they have to use, yet on the other hand, it probably still protects them from any kind of slide through, pass through billing that might happen to occur.
Right.
Okay. I don't know if others are about to jump in here. My next thought or question, and again, I guess this is for either one of y'all, and you don't have to go back to it, but Michelle, can you go back to the methodology that the state will use to set that pricing? And I guess my underlying question will be, how in the world are we as providers supposed to know whether or not that's been adjudicated correctly or not?
So it's an interesting point. So the three categories, I'm going back to that slide, are right here. And this part about whether or not that's the median amount, it's fascinating to me that we're using 2017 rates, first of all. But there is some dispute about whether or not Fair Health has actually received the rates from all different insurance companies in the state. So there are there's some concern that these rates are being set based upon maybe some lower paying insurance providers. And so that's part of the questions to OCI, to the insurance commissioner, is who's auditing it to make sure that all of the insurers that cover these services are included, both the ones that pay on the higher end and the ones that pay on the lower end. So that is a question that's out there. We're going to have to rely on OCI for that. Yes, sir.
Yeah, but the detail of which, or sort of the source material for which we're not really privy to. I guess you're saying ultimately we could subscribe to the same database that they're using and sort of get some transparency there. Is that true?
It is true. So providers absolutely can. And what I heard is that some providers have already been using it, and without a subscription. Like there was some program where you could go in, and I'm just speaking from what someone told me, not my personal action with it, but they could check certain codes. They were limited though, because after that you had to pay for a subscription. And that's where I'm trying to find out from OCI. Do we all, like providers and insurers, have to get a subscription? And then what is the transparency once we're in there? Is it, here's the code, here are the rates that we have, and which payers they're getting that from? Because we as healthcare providers, if you're a hospital, you published all that on your website. So it seems like that transparency of where Fair Health is getting the same amount should be on there as well, but I do not know if that is actually going to be there when we get into those subscriptions.
How do we clarify that? It sounds like you asked DOI, OCI.
Yeah, I've reached out to OCI. So as soon as I get an answer on that, I'll flip it back out to this group.
Okay. My next question, I was waiting to see if anybody else had a question, but my next one is, okay, I get that the arbitration mechanism, at least it's a line of sight and we can see it. Does it have to be on an individual claim basis, or is it for sets of claims? It just seems highly impractical to expect a particular provider to take individual claims and submit for arbitration when the difference may be a few $100.
Yeah, you can do sets of claims. There's also some exceptions to the arbitration, and I didn't touch on this earlier, but it'll be interesting to see what happens here. The commissioner has said that if the claim is subject to a binding claims resolution process that was entered into prior to July 1st of this year, then the claim would be outside of the arbitration and it would go through whatever that claims processing resolution process is that you agreed to with the insurer. So now, of course, if you're in network, you've got that in your contracts. When you're out of network, you'd actually be entering into those types of agreements with an insurer before July. But it can be, the arbitration can be a single payment or it can be a single type of healthcare services. It can also have multiple types of healthcare services and multiple patients all in one arbitration.
Okay, that helps quite a bit.
Mm-hmm.
Okay. Anybody else have any questions for George or Michelle?
Hey, this is Kelly. Not a question, but Michelle, you had referenced sort of the health plan portion of this and posting information online about network status for hospital-based providers. Just want to confirm almost all of the major health plans launched that on 1/1 of this year. So that information for almost every plan is accessible online now.
Yeah, and to editorialize that point, Michelle, has also been used for public flogging purposes, as in, you know, now you're outed if your emergency room group isn't in, and so we're gonna make sure the world knows to stay away from you, kind of thing, and has been used to leverage against us thus far.
Yeah, I totally agree.
Yeah, thank you. I was hoping for more brilliant insight. No? Okay.
I will tell you that I was at a conference speaking on a panel, and one of the individuals who was very supportive of that law was in the healthcare provider side of the industry. So I was very surprised by their support for that law that was coming out.
Yeah, and if I was a hospital that was fortunate enough to have all my hospital-based providers either employed where I controlled that, or had enough leverage with them that they were all contracted and there were surrounding hospitals that were not, I'd be in favor of it as well. But that's not typically the case for a lot of the rural providers that we work with, because if I don't command enough volume to make you do that, then you're kind of left trying to get them to, to play with you in the first place. And so that's kind of a tough conversation.
Right.
And Mike, we do have a question in the chat.
Yeah.
Does state HB 888 have any provisions for the ancillary services such as anesthesia, rad, pathology, similar to what was mentioned in the federal law?
As far as those providers would be considered governed by this Georgia law as well. So it would be similar to the federal law. Is that the question, Aaron? I mean, they're going to be subject to these surprise billing rules as well.
Yeah, that's what it sounds like.
Yeah. And that's where the biggest risk has been. It's your anesthesia group is not in with the blues, but the hospital is. And that's where the patient dissatisfaction has hit a lot of our facilities.
And so again, describe to us what if the anesthesia group can't pursue or has these rules around their out-of-network bill, what is the risk back to the hospital?
Well, it goes back.
Go ahead.
Yeah, it goes back to our database where everybody knows, A, they're out, and so that could discourage somebody from going there. And then a lot of this is just the patient satisfaction side of it. So the goal here would be that if they have to be paid that amount, the patient's protected. And so hopefully that helps the provider avoid some of those patient dissatisfaction issues.
Yeah, understood. LaVonda asked, LaVonda asked the effective date of the state and federal. The state's 1/1, right, Michelle?
It is, yeah, and they've published both their statute and they published their proposed or the final rule. So it's in effect and operating today.
And on the Fed side?
George, do you want to respond on the Fed side?
I'm sorry, I was on mute there. Mike, this is George. Most of the provisions come into effect January 1, 2022. So we've got a little time to get ready for it, but not much. And certainly we'll need to take into consideration the regulations that come out later this year.
Gotcha. This one's a little bit out of left field as well, either one of y'all. For the transparency law, the payer version of that was supposed to start 1/1/22, I think. Do y'all have any update to that? Any specifics around that? Am I on my own here?
No, I don't. But we can look into it and give you an update on it, and we can send it out to everybody.
Got it. Okay. Any other questions? Anybody? Okay. All right, Aaron, I'll take it. We'll switch now on to a quick COVID update. And I'm going to kick it to Kelly Mooney in our office for that. We'll zip through some of these real quick. Kelly?
Thanks, Mike. So a couple of new announcements have come out from Health and Human Services this week about some new funding opportunities with remaining provider relief funds. So this Monday, HHS has expanded on their HRSA uninsured portal, which has been open since last year. I know most everyone that we work with has been filing claims and being reimbursed for either COVID testing or COVID care for uninsured patients. They've now identified sort of another need for that and have established what they're calling the COVID-19 Coverage Assistance Fund that is really dedicated towards uncompensated care for delivering vaccinations to an underinsured population. So we've already got the uninsured portal open, and now this version is for COVID-19 vaccine admin fees for insured population. And so They are going to be compensating providers for eligible claims at the national Medicare rates. And in March, those rates increased for the Johnson & Johnson one shot to $40 per administration, and for the Moderna and Pfizer double shots to $80 for the entire series. Next slide. To be eligible to file, the providers have to administer the vaccines regardless of the recipient's ability to pay for the vaccine. They have to administer it no out-of-pocket cost to the patient, and they have to first seek appropriate reimbursement from the insurer of record for that patient. And they will accept eligible claims dating back to December 14th. So anything back in that now close to 6-month period, they will accept claims filed for those services. Next slide. And what it will cover will be the vaccine administration fees, as well as any patient cost sharing related to the vaccination, including copays, deductibles, and coinsurance. That's why it has to have the documentation from being filed to their healthcare insurer. So we've got the details in here, and all of these slides will be accessible, but the enrollment is open now. It'll be separate from the HRSA uninsured, so a new registration to submit those claims to what they're calling the Coverage Assistance Fund. So next slide. And then additionally, HHS and HRSA are going to be holding 2 webinars about this topic. One is tomorrow at 2, and then next Wednesday at 2 o'clock. So, you know, encourage all of our clients to register for one of those to get the details and start submitting eligible claims. Okay. Yesterday, HHS further announced that they're taking $1 billion of that $8.5 billion that came from the American Relief Plan or Rescue Plan for rural health providers. So they are going to be allocating that money in sort of three separate paths. The first is for all of the RHCs in the country. So they've set up the HRSA Rural Health Clinic COVID-19 testing and mitigation program. So there's going to be $460 million dedicated to the 4,600 RHCs across the country. So HRSA will be providing up to $100,000 per RHC clinic and will issue the funds this summer. And then secondly, about $400 million is going to be distributed to existing grantees of the Small Rural Hospital Improvement Program to work with about 1,700 small rural hospitals, those with fewer than 50 beds and critical access, on COVID-19 testing and mitigation. And again, the funds will be available this summer up to $230,000 per hospital. Next slide. And the last pool of money, another $100 million, is going to be available to RHCs, but this will be through a grant program that will have an application process. So it's related to the COVID-19 vaccine uptake, to do education and reach out to communities that have been underserved. Details of the application process are still coming, but as soon as those are available, we will, of course, get those out to the RHC clinics. Next slide. And what we still don't know from HHS, still additional funds to be dispersed, about $32 billion, and we should now see about $7.5 billion of that left in the rural specific distribution. And then still no updates on the eventual reporting on the use of those funds. No additional information has yet come out from either HHS or HRSA on that process. Next slide. And just a couple of reminders for groups that are eligible for the PPP program, either their first round or second round. Just a reminder that application process will close at the end of this month. And then Medicare sequestration, the legislation had passed to put that back on hold through the end of this year, and that should be reflected in all of your Medicare and Medicare Advantage payments. Mike, you want to take it to wrap it up?
Yeah, anybody have any further questions? We're, I guess just to kind of preview what's coming, we'll have another COVID update in a few weeks. We're also working to pull in Frank Berry and the DCH guys to give us an update on state health plan, Medicaid waiver, the unapproval of that, the several things that are working in their area. And we're looking for the next few weeks to do that one. That said, any other questions for today? All right, Aaron, back to you.
Alrighty, well, thank you all for attending today's webinar. We will be posting the recording and the slides to our website at shpllc.com/webinars. And as soon as the dates are announced for the upcoming webinars, they will be posted there as well. If you do have questions that we weren't able to get to or something springs to mind later on, please feel free to reach out to us. You can contact us via our website at shpllc.com. And I will give you 12 minutes back to your day. Thank you for coming.
Thanks, y'all.